We shall now go on to our next speaker, Dr. Ghulam Ali Kamdar, who's the director and of the Kamdar Eye Hospital at Jodhpur. And he has another interesting situation to show. On to you, Dr. Ghulam Ali.
Good evening, ma'am. Am I audible?
Yes.
And my video is visible too?
Yes.
Yeah. Thank you, madam. Thank you for opportunity. And this is again, I think, the third case of journal dialysis. And I did same mistake as previous surgeons did. I made an incision at journal dialysis area. This is the case of the traumatic subluxated cataract with closed funnel retinal detachment. So we planned a phacoemulsification with the CTR and capsular hook, and VR surgery for the retinal detachment. We chose CTR because subluxation is only 3 to 4 o'clock hours, as shown in the video, and 2 side ports were made for the instrumentation and 1 small step incision for the capsular hook, and 2.8 millimeter main port for the phaco, and then we inject the trypan blue in the AC to stain the white cataract. And after staining, we started a capsular access, initiated with the 26 gauge needle cystatome. It started from opposite quadrant from jonular dialysis, slowly, very patiently, to avoid the stress on the weakened jonule, and it's beautifully completed. As in previous two presentation, both of them inserted the CTR after phacoemulsification, but I always insert the CTR before doing hydro or after hydro procedure. In this case, I put capsular hook first to stabilize the capsular bag to the equator, then put a viscoelastic again, and then preloaded CTR inserted slowly just under the anterior capsule. This is beautifully seen in the video, just below the anterior capsule. Very and after the insertion of this CTR, I did hydro procedures very gently and ensure good rotation of the nucleus. A patient is actually 45-year-old and the cataract was very soft, and phacoemulsification, I did phacoemulsification with direct chop method, and I using the very low parameters to reduce the stress on the weakened jonules. The phacoemulsification completed uneventfully, and after that I clean up the whole cortex material, and then I hand over this surgery to our VR surgeon for vitreoretinal surgery. Thank you.
Thank you very much, Doctor. I just wanted to, it was a nice video to see. If you're, just a thought, if you're actually going to place a CTR a little later, would you want just 1 capsular hook and might have placed 2 capsular hooks? And of course, the incision location, again, which you had already accepted, would have been in a different position. If you are placing a CTR earlier, maybe 1 capsular hook is fine. When you want to do it a little later, then if you have the bag nicely stretched with 2 or 3.
At that situation, we need more hooks, ma'am. But yes, I put only 1 hook because I planned earlier insertion of the CTR.
Yes. Now, the other question which I have is, supposing the amount of subluxation was actually more, I would want Ramurthy, Mohan or Rohit, anybody to tell me, how would you center your axis? You need to decenter it, but how do you exactly do it? On a flax, how you do it? How manually, how would you do it?
On a flax, it's easy to center it. You can actually center it very nicely with a flax. You can do the pupil centered on the thing which is on the flax. In the manual, it's very difficult. You can probably, sometimes you might have to do it only after the lens implantation. Probably you have to this thing, because invariably decentered.
Yes.
But what I would have done differently from what he did was, I would have put the CTR much later. The CTR not at the beginning of the surgery, because the the capsular hooks are good enough for you to go ahead with the cataract. In case there was a posterior capsule rupture, which can also happen because subluxation cataract, then you are in double trouble, because you are having a CTR in the bag that has to be taken care of, and there'll be a problem. So the capsular hooks are good enough to have the support. At the end, you probably put the the capsule. I'm sorry, the CTR.
But again, if it is a traumatic cataract, maybe a CTR could have sufficed in the situation. But if it is a little likely to be a progressive kind of a situation, like a pseudo exfoliation, then a CTR with a CTS would have been needed, not just a CTR alone. Dr. Rohit is itching to say something. You have to tell anything?
I think Dr. Mohan Rajan has aptly put forth the point about the timing of CTR.
Yes.
Once, if you put capsular hooks, then you can delay the putting in of the CTR.
Yes.
CTR, when to put first, when after putting capsular hooks. That is another thing which we have to be absolutely clear. If the nuclear fragment is hard, then you can delay it, because when you are aspirating, the nuclear mass doesn't allow the capsular bag, the fornices of the capsular bag, to be aspirated by the fluidics, because that hard nuclear fragments prevents it. But if it is softer, then in between the capsular hooks, it tends to come with your fluidics. So if the if the nucleus is soft, then CTR can be put earlier on.
Yes.
But if it is hard, you can delay it, because putting it is also not without problems. As he has said, if there's a capsule rupture, you'll end up in a soup. So that is another important. And you can use nuclear scaffold also to
nucleus, sir. Yeah, exactly. Dr. Kapil, you have anything to add?
I totally agree with Dr. Mohan Rajan and Dr. Rohit.
Yes.
An excellent surgery done, Dr. Kamdar.
Yes. Yes. Excellent surgery. Dr. Ramurthy, anything? Shall we go on to the next speaker?
Very nice surgery, Dr. Kamdar. And I think he manually, beautifully decentered the rexus. That's what I noticed.
Yes.
I mean, the way the positioning of his rexus was very apt. The only doubt is more regarding the principle involved. This was a patient who required a vitreoretinal surgery also. And he handed over the case to vitreoretinal surgeon. Whether this would have been a case for just removing the lens, doing the vitreoretinal surgery, and doing a scleral fixation by our vitreoretinal colleagues. And how far we go as far as handling these subluxated lenses and trying to fix them onto the back is something that you keep wondering.
Yes, true.